To perform an examination of any body joint, we use these steps: look, feel, move, perform special tests, depending on the joint being examined. To perform a complete knee exam, follow the following steps. Wash your hands, introduce yourself and confirm patient ID. Position patient and ensure privacy. Explain examination and take consent. Expose both legs and knees to mid-thigh. At the start, you will need to assess gait and joint alignment. Ask the patient to walk away from you and then back, looking at the antalgic gait. Then for alignment, ask the patient to stand facing you, patella facing forward with the feet together and pointing straight ahead. To assess knee alignment, look with the axis of the thigh to the axis of the tibia. Always compare with the patient's other side to differentiate between a mild deformity and a normal variant. Agenu valgum, locked knees, when the angle formed points towards the midline. Agenu verum, when the angle formed points away from the midline. Look. Ask the patient to stand up. Look at the front, sides, and back. Compare both the right and left legs, knees, and thighs. Note any skin changes, erythema, deformity of a varus or valgus, scars from previous surgery or injury, swellings from rheumatoid arthritis, septic arthritis, gout, Becker cyst, muscle wasting. Note any wasting of the hamstrings, gastrocnemius, tibialis anterior, and the quadriceps. A quick review of surface anatomy before palpation. Patella, quadriceps tendon, patellar tendon, tibial tuberosity, lateral tibial plateau, medial tibial plateau, lateral epicondyle, medial joint line, lateral collateral ligament, medial collateral ligament, medial condyle, lateral condyle. Head of the fibula, vastus lateralis, vastus medialis. Biceps femoris, semimembranosus, semitendinosus, gastrocnemius. Popliteal fossa is a gap between the inferior hamstrings and the superior calf muscles. Feel. Warm your hands. Before touching the patient, ask if they are in any pain. To assess temperature, rub your hands together to warm them. Place the back of your hand around the joint. Do this bilaterally to compare both sides. Bony prominences. Start by palpating the tibial tuberosity, patella tendon, the patella, femoral condyles, head of the fibula, and move your finger upwards to palpate the lateral collateral ligament. Similarly on the other side, between the femoral epicondyle and the proximal tibia, palpate the medial collateral ligament. Joint line. Ask the patient to flex their knees to 90 degrees. Identify the anterior portion of the joint line with an index finger, locating the joint space, just medial to the patella, between the femoral condyle and the tibial plateau, and run your finger all the way to the back. Repeat the same thing on the other side. First locate the joint space, this time laterally to the patella, between the femoral condyle and the tibial plateau. Run your finger laterally all the way to the back. Tenderness to palpation along the medial or lateral joint line is amongst the most sensitive signs of a meniscal tear or lesion. Patella, palpation of the patella. First, the patella glide test. Palpation is completed by checking patellar mobility. The examiner pushes the patella medially, then laterally, increasing excrusion to the lateral side identifies patients who are at risk for patellar instability. To elicit patellar tenderness, shift the patella to one side with one hand, and with the other hand, work your index finger or thumb under the patellar facet as far as possible and press upwards. Look at the patient for signs of discomfort. Do the test for the other side. Move. Start with active movement. Ask the patient to extend and flex their knees. Comment on the range of movement and compare it with the other knee. If the patient isn't able to actively move their knee or feels pain, then you should move on to passive movement. Ask them to relax as you move their knees for them. Don't forget to feel for any crepitations. Special tests. To assess the integrity of the anterior cruciate ligament, perform the anterior drawer test. Flex the knee to 90 degrees. Make sure the hamstrings are relaxed. Stabilize the foot by sitting on it. Place your fingers in the popliteal fossa and thumbs on the tibial tuberosity. Pull the leg forward. Normal forward movement should not exceed 3 millimeters. Lachman's test. This is the most sensitive way to assess the integrity of the anterior cruciate ligament. Flex the knee to 30 degrees. Place one hand medially, distal to the knee, and the thumb on the tibial tuberosity. Place the other hand laterally, proximal to the knee. Make sure the quadriceps are relaxed. Stabilize the hand proximally to the knee and pull the tibia forward with the other hand. An intact anterior cruciate ligament prevents forward movement. To assess the integrity of the posterior cruciate ligament, perform the posterior drawer test. Same as before, follow the same steps of the anterior drawer test, except this time you're going to push the leg back to assess the integrity of the posterior cruciate ligament. To assess the integrity of the medial collateral ligament, perform the valgus stress test. The valgus stress test checks for medial joint laxity, which usually represents an injury to the medial collateral ligament, or the MCL. Create a valgus stress with the hand placed distally, with the knees at full extension, then again at 30 degrees of flexion. Another way to perform the test is to place the foot under your armpit. A positive finding demonstrates an increased medial joint laxity compared to the unaffected side. Increased laxity to valgus stress with the knee in full extension signifies damage not only to the medial collateral ligament, but also to the posterior medial capsule. An abnormally increased valgus laxity when the knee is flexed suggests more isolated damage to the medial collateral ligament with intact posterior medial capsule. To assess the integrity of the lateral collateral ligament, we do the varus stress test. The varus is the counterpart of the valgus test. The varus stress test checks for joint laxity on the outside of the knees, which usually represents an injury to the lateral collateral ligament. Positive finding demonstrates an increased joint laxity compared to the unaffected side. Increased laxity to the varus stress with the knee in full extension signifies damage not only to the lateral collateral ligament but also to the posterior lateral capsule. An abnormally increased varus laxity when the knee is flexed suggests more isolated damage to the lateral collateral ligament with an intact posterior lateral capsule. Test for effusion. Perform the milking test for moderate effusion. Push the fluid up on the medial side, then push the fluid down on the lateral side, looking for any bulging in the medial fossa. The patellar tap test is for severe effusion. Squeeze the suprapatellar pouch. Then tap the patella with the other hand. Feel for a tap, which would indicate a larger effusion. To assess the stability of the patella, Perform the patellar instability apprehension test. Make sure the quadriceps are relaxed. Push patella laterally with one hand and flex the knee with the other hand simultaneously. Look at the patient's face for any signs of tenderness indicating a positive test, which suggests a lateral patellar dislocation. Finally, to complete the knee examination, perform a neurovascular examination and examine the joint above the hip and the joint below the ankle.